Good morning, good morning, good afternoon, wherever you are. My name is Julienne Anoko. I'm working at the WHO Regional Office for Africa in the Emergency Preparedness and Response Department. Dear partners, dear colleagues and participants, I would like to acknowledge colleagues who are joining very early in the morning. Thank you for your commitment to join this webinar. The purpose of this event is to update you on the International Health Regulations amended in 2024 and the WHO Pandemic Agreement. In 2024, in 2024, the WHO Health Assembly adopted amendments to the International Health Regulation. And in 2025, in accordance with the Constitution of the WHO, the organization adopted the Pandemic Agreement. In July last year, the Director General of the WHO notified to state parties the above amendments to the International Health Regulation that are due to enter force in 19th of September 2025. These legal instruments, designed to be complementary, are poised to strengthen global health governance and, in particular, coordinated multi-sectoral, multi-stakeholder actions to prepare for and respond to public health emergencies. As countries of the WHO African region prepare for implementation of the International Health Regulation as amended in 2024, and these countries are continuing their intergovernmental work to finalize the annex to the WHO Pandemic Agreement, it is critical for us to provide clear orientation on the legal and practical articulation of this very important tool instrument. We have prepared several presentations to update you on the International Health Regulation amended and the WHO Pandemic Agreement. I would like to give the floor to Mrs. Pearl Kobuyenje to present the objectives of the webinar. Over to you, Mrs. Kobuyenje. Thank you.
Thank you, Dr. Anoko, and good morning, good afternoon to everyone. Today's session marks the first in a three-part series to help us deepen our understanding of the International Health Regulations and its amended articles. Today's focus will be on Articles 1 to 18, which is Parts 1 to 3, which will cover the foundational aspects of the IHR. We will go through these changes and what they mean and how they relate to your role. We strongly encourage all participants to join the full webinar series because each session builds on the last. Session 2 on 30th July will take us through Articles 19 to 54, and Session 3 on August 13th will focus on the WHO Pandemic Agreement that was adopted in 2025. This webinar series will help participants understand the specific IHR amendments and prepare state parties for their entry into force on 19 September 2025, and to align with the requirements of the amended IHR and the Pandemic Agreement. Next slide, please. So our expected outcomes for the webinar series are, firstly, to ensure that all state parties have a good understanding of the key IHR 2005 provisions and its amendments, those that were amended last year and adopted last year. Secondly, we want state parties to gain clarity on the next steps particularly as we approach the deadline of 19 September, which is the deadline for entry into force. And finally, we want the sessions will aim to strengthen an understanding of the WHO pandemic agreement and the next steps leading to its prospective entry into force. Again, I would like to stress that today is the first of 3 sessions, and the full value of the webinar series will come from attending and engaging in all 3 sessions. So we encourage you all to attend the next 2 sessions as well. With that, I will now hand over the floor back to our moderator, Dr. Julienne Anoko. Thank you.
Thank you very much, Mrs. Kobuyenje. Colleagues and participants would like to go back to ask our colleague, Mrs. Abianuru Amarashi, to take us to the housekeeping. Thank you very much for your patience. Mrs. Amarashi, over to you.
Good morning, colleagues. Good afternoon, and from wherever you're joining us. Can I have the housekeeping slides up now? So I'm just quickly going to run us through a few housekeeping rules so that we are on the same understanding of the Zoom platform and the WHO session. Next slide. So we have interpretation in English, French, and Portuguese. Please feel free to navigate the buttons below at the bottom of your screen, where you see a globe icon that says interpretation. So if you click on it, you can move between English, French, or Portuguese as we go through the session. Please use the Q&A for questions regarding the topic and the technical content for today, just the Q&A. Please ask your questions in the Q&A session, and use the chat for general introductions like we're already doing, and questions regarding IT and logistics. From our side, we'll also be using the chat to send you some links or some resources. Please also pay attention to that. During the live Q&A sessions, when the moderator tells us that it's time for the live Q&A, please use the raise hand feature. If you look at the bottom of your screen, you're going to see a raise hand feature, and the moderator will ask us to give you access to speak, and then you can ask your question live. Next slide. By participating in this webinar, either as a participant or panelist, we take your attendance as permission to record your contributions, and we will be sharing these recordings with you participants who are in the room today, but we're also going to be sharing these recordings on our various learning channels. The session materials, which will be the presentations and the recordings, will be shared with us in the days following the webinar. Next slide. Next slide. Great. For the agenda, our moderator has already taken us through the objectives and the housekeeping, and I will just quickly run through the panelists on the call before I hand over to our moderator. We have our program area manager for the health emergency preparedness unit, who is Dr. Dick Chamler, and we also have Dr. Kola Jinadu on the call with us, who will be running through a few presentations with us, and he is also from the WHO AFRO. We also have Andrageti Roberta, who is our colleague from the WHO HQ, and she will also be running through some presentations with us. On the call too, we have our team lead and for the emergency preparedness unit currently in the Nairobi hub, Dr. Miriam Nanyuja, who will also be running through a few sessions with us. Next slide. So welcome everyone. Let's begin. Over to you, Dr. Julian.
Thank you very much, Mrs. Abianuru Amarashi. Please join me to welcome Dr. Dick Chamler, our Program Area Manager for Emergency Preparedness Dr. Dick Chamler, please take the floor to deliver your opening remarks. Thank you very much.
Yes, I really appreciate it. Good morning, everybody. Bonjour à tous. It gives me a great pleasure.
Dr. Chamler?
Yes.
Dr. Chamler, please, can you switch on your video? Sorry, we cannot see you, Dr. Chamler.
Yes, the problem, we didn't have electricity here, so it is only
Sorry.
returning now. So hold on, I'm returning now. Okay, yeah,
Yes.
okay, excellent. So yes, bonjour à tous, all of you, and welcome to this webinar series of International Health Regulation as amended in 2024, and also the pandemic agreement in which it was equally adopted. However, its entry into force, it depends on the prior actions in which it needs to be completed. So colleagues, welcome again. As I stated, my name is Dr. Dick Chamler, and I'm the Program Area Manager for Emergency Preparedness here in the WHO Regional Office for Africa. Actually, IHR amendments are not really new. Historically, we have had the major amendments in 2005, in which they give rise to IHR 2005. And then if you go the history of amendment, it dated years back, over 50 years in which is happening. And oftentimes the amendment are triggered by the events preceding the amendments. 2005, I think you all understand the outbreak of SARS in South Asia, in which it triggers a series of actions and global debates, and see how are we able to amend our international health regulation to be able to support our member states in Asia trying to contain international spread of the diseases without interruption of economic activities. And as you see in the recent amendments also, it was triggered by a pandemic of COVID, in which now we have IHR amendments. So I wouldn't really talk more on the contents of the amendments. I think we have brought a group of experts from the regional office and our headquarters, who they will be presenting you with the contents and what is new as far as the amendments are concerned. From me is only some few points in which I needed to bring it to your attention. Issue one is that of recent years, the compliance of IHR amendments, particularly in our region, has been a problem a little bit in a number of countries. In such a way, there had been hesitation for our member states to declare the outbreak as outlined in IHR Article 6, 7, or 8. So I think it's a plea I'm bringing it to all of you, the member states, with a call, and our country offices, that a WHO system requires a declaration of an outbreak in order to activate its incident management system in line with our emergency response framework. Therefore, any delay in the declaration oftentimes it leads to the delays in the early response. Therefore, it's an issue in which I thought I should actually bring it forward in my opening remarks, because there had been a number of the countries in which we have had such kind of a problem. Issue two also, I needed to bring here to the AFRO. In the recent changes, there had been an adoption of Article 1, I think, in which it says clearly there have to be an establishment of the national IHR authority, in which I think there had been a series of debates in countries, which institution in which it would be better placed to host the national IHR authority, because there had been prior a debate of whether the role of NIA to be interfering with the role of the National Public Health Institutes in some countries. And also there had been some of the debates on how are we able to place it as in the ministry at higher level, and what will be the interaction with our IHR NFP, a structure in which has been in existence in the past 20 years and above. Therefore, we will hear from our experts today on this area. And here in the WHO, we have already started to clearly define our role in supporting the public health institutes in the countries. And another point in which I also want to bring out in my opening remarks is the role of the WHO in this process. As you know, from a time the Intergovernmental Negotiation Body was created, or the working group of IHR amendments was established, the WHO, AFRO, and HQ, they had been in supporting of our member states to negotiate in this process. So our role as a WHO AFRO, I'm glad to let you know that we've been working hand in hand with the Africa Group plus Egypt, in which we were able to host actually the 2 retreats here in Africa to bring our health attaches from Geneva to Africa, and actually they come up with something with the name, the Common Africa Position. So we are glad that a lot of issues which we agreed as a part of Common Africa Position were actually well articulated in the global discourse. And now we have an amended IHR and adopted pandemic agreement in which has reflects interest of our member states in Africa plus Egypt. So also the WHO, we were actually proactively, particularly here in Africa, we also organized the African Parliamentary Conference in collaboration with Interparliamentary Union, IPU, in order to prepare our parliaments in the process of either entry into force or a domestication process, and particularly in pandemic agreement in which it might need to have some sort of the legal framework in which it will be supporting its implementation. As a result, I will reiterate it to you, AFRO will be always there, and AFRO will be still supporting this process until the end, at the time we are completing all the annexes of the pandemic agreement. And the last point from me is really to come into understanding a global health ecosystem is changing. As you are all aware, we have a reduction of ODA, overseas development assistance. We have, I think, one of the major actually member of the WHO who has announced a retraction from its membership from a WHO. It's only to let you know all it has an impact in our implementation. I'm glad to let you know that we have other member states in the WHO in which have equally started to increase its contribution to WHO and also committed to support our process until the end. Therefore, with only few remarks, I see Anoko is looking at me, say his time is over now. I'm wishing you all the best in your deliberations and the actual merci à tous. Okay, to you, Anoko.
Thank you very much, Dr. Chamla, for taking time. And thank you really for setting the scene and ensure the WHO AFRO commitment to support member states to implement the IHR amended. So thank you very much. Participant colleagues, please don't forget you have the Q&A. If you want to write your question, our expert in this call will be very happy to respond to you using the Q&A session. Thank you. So I will give the floor to our first expert, Dr. Kola Jinadu. Dr. Kola Jinadu will take us through the overview of the International Health Regulation, including the monitoring and evaluation framework and progress on the implementation of the International Health Regulation. Dr. Kola Jinadu, thank you for your presentation. Please, you have 20 minutes, and time is really something like to really respect it. Thank you, and over to you.
Thank you so much, Julian, for that introduction. And to my colleagues on the call, I welcome you to this webinar. My job is simple, really. It's just to take you through the overview of IHR 2005 and IHR Monitoring and Evaluation Framework, and also to look at the progress that have been recorded so far. If you look at this first slide, I'm sure maybe you perhaps expected us to reject something that has blue cover. That's the IHR 2005. But let me say at this point that this has been amended, and this is the current page that is being used. This might also change by the time it enters into force by September 19, 2025. Just to introduce to you so that you'll be wondering why we're having this blank, this kind of plain page for the IHR 2005. Next slide, please. So this is going to be the outline for my presentation to talk about the global health security in context and also to introduce you to the IHR 2005, the purpose of this IHR, what are the core capacities required from countries to be able to strengthen their health security. So we're also going to go through the key IHR articles just to foster our understanding. And of course, the roles of member states and that of WHO will be discussed. And towards the end of this presentation, we are going to look briefly at the overview of the IHR monitoring and implementation framework, and I will end with key messages. Next slide. The overall objective of this session on IHR is to update national authorities, including the national IHR focal points, WHO country office teams, and other key stakeholders on this call on key provisions of the International Health Regulations 2005. Next slide. Yes, we'll be wondering that why are we so bothered? Why are we so concerned about global security? The last 10 years, you will agree with me, as they've been unprecedented due to the emergence and re-emergence of infectious diseases in the last 10 years with significant mortality and morbidity. And of course, we might begin to think or wonder that are the pathogens becoming smarter than us? What is exactly the problem? Of course, the role of mutation of these pathogens cannot be overemphasized, as well as issues around climate change, resulting in emergence and re-emergence of these infectious diseases. The globalization and the spread of the diseases is also very, very important. I think in 2005, when this regulation was adopted, the total population, the global population was around 6.2 or 6.5 billion. Now, as at last month, on the 30th of June, the projected population was around 8.2 billion. That's almost 2 billion increase in the total number of world population. And given the interconnected world that we now live in, you see that we are vulnerable because of the traffic and across our borders, and of course, the increased travel of citizens all over the world. We also have unusual and inevitable disease events. I know that we have our risk calendar to be able to predict which events will happen in the next few months. However, we can't still absolutely say yes, there will be some particular diseases at a point in time because of the fact that some of them, they just occur sporadically. No, they occur without any kind of expectation or prediction. And we have deliberate use of biological and chemical agents, laboratory and industrial accidents too. We know that they use some biological and chemical agents for bioterrorism. This is also something that we should have at the back of our mind, why we should be concerned about ensuring we have global security. The impact on health, economy, and security cannot be overemphasized. This was witnessed particularly during COVID-19, whereby we have a kind of discontinuation of essential services. Of course, the economy was affected, were affected globally, and of course, the impact of security is also very, very important. So these are the issues that we should begin to reflect over because they are critical to securing international health. Before I move to the next slide, just to let us know that the IHR, it has a long history, the framework, it has a long history, not that we are just amending it now. Since WHO came into existence in 1948, we had what we called International Sanitary Conference, which was held. So we had international sanitary regulations in 1851. But 3 years down the line, when WHO was established, WHO adopted the International Sanitary Regulation to ensure that we secure international health. And in 1969, this was further reviewed to now become become international health regulations due to the fact that if you look at the name International Sanitary Regulations, which was adopted in 1951, it attributed diseases mainly due to insanitary conditions. But because of science, because of evidence, and because of the advancement in technology, and of course, scientific professions in the literature, it was realized that there were other causes or causations to diseases outbreak beyond just insanitary conditions. And that was why it was changed to international health regulations. And down the line, some people, it has also been documented that severe acute respiratory syndrome, that is a pandemic that came to the world in the fall of 2002, actually gave rise to the 2025 IHR, which was adopted in 2025 and subsequently came into force in 2020 and 2007. In 2005 and later came into force in 2007. So there is a very long historical background to this contest, and this is what we should understand. And like the Dr. Dick said, this is not the first time that we are amending the IHR. So it has been amended over the years since 1969. Next slide. So just to introduce you to the IHR 2005, like I said, it came into force on the 15th of June 2007. It can be described as an instrument of law or legal instruments agreed by the state parties to manage epidemics and other public health emergencies. And again, it is legally binding on WHO and the member states that have agreed to this important framework, and they are expected to abide by the rules to ensure that we secure international health. And I would like to share this quote by the current DG of WHO, Dr. Tedros, and I quote, "We live in a world at constant risk of public health emergency. In our increasingly interconnected world, public health emergency can affect anyone, anywhere. So no one is safe. So that's why we need to really come together and ensure that we secure international health." Next slide. So just to take us through the structure of the IHR 2005, it has 10 parts, 66 articles, and 9 annexes. For the purpose of this session 1 of the webinar series, we are going to take you through the part 1 to 3 of these articles. Part 1 is looking at the definitions, purpose, and principles, as well as responsible authorities. That will be covered under Article 1 to 4. Then for the part 2, we are going to look at Articles 5 to 14 on information and public health response. And part 3 will be the last article for this session for this particular series, which is going to cover Articles 15 to 18, which is going to focus on recommendations. Other components of this, other parts of this IHR will be covered in the subsequent webinars, which will take place on the 30th of this month. This is July, and of course on the 13th of August. So let me quickly run through the different parts of the IHR. Next slide. Yes, there is a fundamental principle in IHR, which is the need for us to contain any kind of event at source. And this is actually this is very, very important given the jet age that we currently live in. And we know that there has been a lot of advancement, especially in travels. You can wake up at 12 midnight and decide that you want to be in another country by 5 a.m., just within 5 hours apart. So over the years since 1940, we have witnessed a significant progress in technology advancement, especially with the use of a jet-driven engine that has more efficiency, and of course that can reach different destinations within a very short period of time. And as such, because of the globalization that I mentioned earlier, people travel from one part of the world unknowingly with pathogens that they might not be aware of. So just like what we experienced during COVID-19, when we have most of the countries affected with that condition. And it's important for us to ensure that we rapidly detect and respond any kind of emergency at source, regardless of wherever they are happening, whether it's going to be at the subnational level or at the national level. But the issue of multi-sectoral collaboration and cross-border collaboration becomes more important there because of the fact that if you have an outbreak in a particular country and other countries are not reporting yet, it's important for us, all of us as member states, to support the country reporting that kind of outbreak to ensure that we control the outbreak at source to limit international spread. And this is very important again, given the context of some of the challenges that we have experienced in terms of information sharing. Without sharing information, we will not be able to detect and, of course, respond to this outbreak in a timely manner. So it is important for us to quickly detect and respond to outbreak by limiting the spread to other countries in the world. So next slide. So looking at the IHR core capacities that we expect the countries to develop, to strengthen and maintain. Look at legislation and policy, coordination, of course, laboratory. And of course, these IHR core capacities, they also apply to, strengthen capacities to be able to prevent or control biological hazard, infectious diseases, those from zoonosis. And of course, food safety too is also a major concern. So we're also looking beyond infectious diseases to consider emergencies that could be due to chemical and radionuclear emergencies, because these are all very, very important. We're now looking at the principle of all hazard control. So all hands must be on deck to ensure that we build and strengthen the capacity of countries to be able to respond to some of these different areas of emergency. And as countries, as state parties, it is important that we consider the three levels when we are building these capacities. The first is at the national level, the intermediate level where we have such, and of course, the peripheral and community level. For us to build the capacities across this level, because in my last slide, I mentioned the need for us to contain this outbreak at source to limit international spread. We're also looking at events at the point of entry, which is the gateway of entry of any disease into any country. So it's also important for us to build the capacities at the point of entry so that we're able to detect in a timely manner and mount effective response to limit spread of outbreak. So the importance of linking public health with security is also a very important component we should begin to reflect upon and how we can support countries, because it has also been reflected in some of the evaluation tools being used by WHO on the need to link public health with health security. Next slide. So I'm just trying to be brief on this one about the IHR and declaration of fake. We are going to touch more on this when we are discussing IHR amendments, because we have a lot to actually inform you about on this particular declaration of fake. That is public health emergency of international concern. So declaration of fake, now we are looking at a determination of fake. We are not using the word declaration again. I just left it there for a purpose that before a fake can be determined and announced. So on receipt of information on the potential fake, the DG of WHO convenes the meeting of the IHR Emergency Committee. And this committee, their role is to review information available and advises if the event actually constitutes a fake. So there are different criteria that we are going to be looking at to determine whether an event constitutes a fake or not. Then after the consultation with the affected country, the DG cannot, of course, can announce this and not declare the fake. Next slide. So I believe that some of us we are familiar with this decision instruments for us to be able to notify WHO on events that may constitute a public health emergency of international concern. So I'm going to run through this because we are still going to touch on the amendments that have been made to this particular decision instruments in the subsequent sessions. If you look at the top left side of the slide, you can see that there are 4 diseases that should be notified immediately to WHO. These are smallpox, polio, due to white type polio. But in the amended one, this has changed. We are going to discuss. I don't want to buttress so much on that. We also have human influenza caused by a new subtype. And last but not the least is the SARS, severe acute respiratory syndrome. So all these 4 conditions, you are supposed to notify them immediately.
Dr. Kola, you have 5 minutes to go. Thank you very much.
So these are the criteria that are normally used to notify, to decide on notification if the public health is of if it's of public health, if the public health impact of the event is serious, if the event is unusual or unexpected, and of course, I will refer you to other ones as you can see on the screen. And in using this instrument, there are other conditions that you can also use the instrument for. For instance, if you have any event of international public health concern, or if you have like an unexpected number of cases, or they occur unusually, you can also use these instruments. There are also other conditions that you can also apply these instruments to. For instance, when you look at cholera, pneumonic plague, because of their propensity for international spread. So you can also use these instruments. So I encourage colleagues to go through these very important instruments. Next slide, please. So what are the key articles for discussion now, at least just to introduce you to the concept of the key articles within the IHR 2005. If you look at Article 4, which said that the national focal point for IHR should be designated at the country level. And of course, the designation of the WHO IHR focal point is also expected. So the caveat to this is that this designation of the national focal point within the country, the national focal point is supposed to be available 24/7 to respond to any kind of call on, regarding public health emergency. So if you are called at midnight, if perhaps you're unable to pick the call, you are not aware, the expectation is that you return the call as soon as you see that call. Then the second part is on the Article 5, which is to establish the capacity to detect, assess, notify, and report public health emergencies. We have also had some modification to this in the current amendments. And the role of WHO is to ensure that we support the member states to actually put these capacities in place. Under Article 6, notification, the national focal point is expected to assess events using the decision instrument under the Annex 2 and notify the WHO within 24 hours of potential public health emergency of international concern and response measures being taken. Article 7, member states obligation to share information if having unexpected and unusual events. So the obligation, all these are going to be touched. We are going to describe this when we get to the session on the amendments on what exactly the countries should be doing with regards to this article. But just to tell you the provisions of different articles for your information. Article 8, if member states, if they have inadequate information or not sure of response to a particular event, there is a room for consultation with WHO, or they may also request for technical assistance to support them. Under Article 9 is looking at other reports that WHO may consider reports from other sources and ask member states to verify them. Like I said, I'm just trying to walk you through some of the important articles and what they state. For your understanding, all this will be discussed when we look at the amendment that have been made to some of these articles. Next slide. So on Article 10, it has to do with verification that within 24 hours of countries receiving verification requests, that's from WHO, countries are expected to give initial response to acknowledge receipt of such requests within 24 hours and to provide information to WHO about the public health emergency. WHO can offer to collaborate with country in verification if necessary. If justified by the magnitude of the risk, WHO may also inform other member states of the events, even if country has undertaken any kind of verification. WHO is responsible for sharing information on public health emergency with other countries and where necessary with the public. So there are different conditions to this. which will be discussed further under the amendments. For Article 13 is looking at the response, public health response. Member states are expected to build capacity, to maintain capacities for prompt and effective response to public health emergencies. And the role of WHO in this context is to support member states in implementation of effective response by providing technical guidance, by supporting monitoring and response to the emergencies, and as well mobilize international teams to support response activities in member states. Next slide. I'm coming to the end of my slide now. Article 14 is looking at the cooperation that WHO cooperates with other intergovernmental and international organizations in the implementation of IHR. It's a joint effort.
We will allow you
Article
5 minutes more. So this session is important. So you have 5 minutes more. Please go ahead.
Okay. So thank you so much, Julian. Article 19 is looking at the point of entry. And this one has to do with the need to designate airports and ports, identify competent authorities, and build the recommended capacity at the point of entry because of the vulnerability around this area, and of course, due to increased traffic. Looking at Article 21 on ground crossing, designates, build core capacities. Of course, there is supposed to be a bilateral and multi-sectoral arrangement for prevention of cross-border transmission of diseases. So I think the activities in terms of building the core capacities around the point of entry and ground crossing is important for us to see how the countries can strengthen their capacities around these areas because of the to limit cross-border transmission of diseases. Next slide. So just to quickly take you the IHR operational framework within the WHO, and of course how this interface how it interfaces with the member states. So at the member state level, I believe that we have a lot of national IHR focal point on this call. If you look at the capacities for national surveillance and response system, including point of entry, we are supposed to build this capacity to detect, assess, report, and respond to public health emergencies. And like I mentioned earlier, as a national focal point for IHR in your country, you are supposed to be accessible 24/7 to ensure constant communication with WHO and to disseminate information nationally and consolidate on the input nationally. So when you are building these core capacities, of course, we expect you to also carry along other ministries and sectors and working closely with other competent authorities. For instance, International Atomic Energy Agency, it depends on the condition. If you have a kind of radionuclear emergency, they might be carried along in the response. And the IHR NFP is supposed to also interact regularly with WHO IHR contact points, who will now, of course, interact with the WHO DG. To determine public health emergency of international concern, DG has the prerogative to make temporary and standing recommendations made upon advised by the emergency committee. And of course, we are going to touch on this as we proceed with this presentation. But the main point here is that both the national IHR focal points and of course WHO IHR contact points, they are supposed to be accessible 24/7 to be able to respond to any kind of emergencies and to provide clarification on any request. Next slide. So I'm coming to the end of the slide. I'm very sure that most of us are familiar with these 4 components of IHR monitoring and evaluation framework, which are 4. The first one is mandatory. It's called State Party Self-Assessment Annual Reporting, SPA. Countries, this is used to monitor progress towards implementation of IHR core capacities. And I must say that we have been recording 100% submission from member states in the last, since this was introduced. We are looking at the type of capacities that should be reported. We have about 15 capacities, which of course I believe that we can also find time to look at them because of time. We might not be able to go through all of them. So it's mandatory. But for the after action review and CMEX and voluntary external evaluation, which is also known as joint external evaluations, I believe our countries have been actually prioritizing these activities to assess the functionality of the capacities during real events. That's for the after action review. for you to assess the potential functionality of capacities during peacetime for non-real events. That is simulation exercise. And for the JE, it objectively evaluates IHR, how IHR contributes to security. So the three are voluntary, and I believe that the countries have been implementing this. In terms of their periodicity, JE is conducted every 4 to 5 years. CMEX is conducted from time to time, especially when we are anticipating emergencies, to be able to test our capacity to be prepared for this emergency. And the after action review, we now call them action reviews. There are three. We have early action review, we have intra action review, and of course after action review. There are three of them, which are conducted at different times. Next slide. Looking at the progress made with the implementation of this review. For the CMEX, since 2022, we have recorded significant number of CMEX conducted and after action review, as well as currently different countries are in their second phase of their JE, and we have about 31 countries that have conducted JE in the region. The last two slides they are looking at the roles of member states in building capacities and competencies to prevent, detect, and respond to public health events. And as you can see, as member states, you are expected to update IHR focal point contacts annually in case there are changes. You also expect to assess and report on IHR capacities annually using the SPART tool, regularly review and evaluate capacities using the appropriate IHR MEV. Report timely public health emergency to WHO based on the IHR guidance. And of course, you can also look at the decision instruments under NS2. Timely response to public health emergencies with the goal of controlling at source, as I stated earlier. And of course, if there's a request for support, of course, you can also ask for such requests from WHO. Next slide.
Dr. Kola, please start to wrap up.
So just to wrap up, on the role of WHO, and in this context, WHO will continue to support countries to build capacity and monitor implementation of IHR. Receive reports about events from different sources, and of course, you can verify by asking the countries those concerned. Consultation is also important with the countries, to agree on some elements. Request countries for verification of reports, especially when you get reports from outside sources. Support to response to public health emergencies and public health emergency of international concern by also issuing temporary or standing recommendations. Assessments of supporting the countries to assess those events that may constitute public health emergency of international concern, and or those that may have possible interference with international traffic, and of course, looking at assessing the adequacy of control measures with international traffic and adequacy of virus control measures. We may also offer support with mobilization of international assistance. Next slide. Fair wrap up. So this is the progress I was trying to let you know about with the IHR implementation in the region. You can see that different countries are implementing CMEX after action review. Past submission has been 100%. Even as at the last submission this year for 2024, we still recorded 100%. For the JE, we have ongoing JEs in the region. About 31 have conducted JE. And the question we should be asking ourselves is that after all this, what have you achieved? What should we be doing? We expect the countries to also develop their NAPs following their JE. And of course, what has been a challenge is the implementation of the key recommendations or following these reviews and exercises. So we should begin to see how we can prioritize mobilize resources to ensure implementation of the key recommendations so that to strengthen our health security. Next slide. So what are the key messages? Sorry, Julian, I have to wrap up. This is the last slide. There's no time better than now, colleagues, for member states to invest more in strengthening IHR capacity for enhanced health security. We need to have more investment. Health security can only be achieved through strengthening epidemic intelligence system by having a robust surveillance system in place to quickly detect any kind of outbreak, cross-border collaboration, and of course, having a regional coordinated response. As each country builds its capacities for emergency preparedness and response, we all win. The entire world wins. Thank you, Juliet, Julian, and over to you.
Thank you very much, Dr. Jinadu. Partners and colleagues, thank you for your attention. We are given 10 more minutes to this presentation because it's really very, very important. And I will encourage you to continue to ask your question in the Q&A channel. Our experts are here to answer to you. Thank you very much. People are clapping. Thank you very much, Dr. Jinadu. So we are going to open a very short Q&A session, very, very short, really. So we will take maybe 1 to 2 questions. So people that have questions, please raise your hand. They will open your mic so you can ask your question. Thank you very much. While we are waiting, I would like to welcome those who have joined. Now we are almost 251 people participating in this webinar, and this is really great. Thank you very much for coming, and thank you for asking questions, and thank you for your attention. I think in our Q&A, we have already several questions. I will ask our expert, please, to go to the Q&A and answer to the questions from our participants. I cannot see any hand raised. So no one has raised their hand, so it means that the questions are on the Q&A. Expert, please go to the Q&A and answer to our participant questions. And now we are going to move on to the next session. And the next session our expert will highlight the amendments of the International Health Regulations adopted in 2024 and the part 1 to part 3. So I will invite our colleague, Dr. Andraghetti. Dr. Andraghetti Roberta is the International Health Regulation focal person at the WHO headquarters in Geneva. Dr. Andraghetti, please take the floor and lead us on this presentation. You have 30 minutes. I think that maybe you will share with Dr. Kola, but you have 30 minutes for this presentation, which is really very important. Thank you for being here and for taking the floor. Over to you, Dr. Andraghetti.
Thank you, Dr. Nanunja. Bon dia, bonjour, and good morning to everybody. And thank you to Dick and the AFRO colleagues for inviting me to join this first webinar. Now, as it was mentioned earlier, we are going to address the amendments that to the IHR that were adopted in 2024 throughout the 3 sessions of this series. Next slide, please. Now, the IHR at the present moment in time is the only international legal instrument that we have related to health emergencies. And this instrument was adopted by member state under Article 21A of the WHO Constitution. And historically, as it was mentioned earlier, it went through 2 revisions in 1969 and 2005, meaning it went through major changes in 2 occasions. And the IHR 69 was amended in 2 occasions, and the IHR adopted in 2005 was amended in 3 occasions, 2014, 2022, and 2024. Now, we are going to tackle the amendments that were adopted by the World Health Assembly in 2024. Next slide, please. Now, we are tackling these amendments, but I would like to stress that these amendments are the result of very intense negotiations by member states, states party to the IHR. Therefore, even if I was a technical lead from the WHO Secretariat of the process, you member states, you should be more knowledgeable that we in the IHR, in the WHO Secretariat are about what the amendments that you have adopted are intended to do, because they are your amendments, they reflect your needs and wishes. And do not forget how hardly you have fought for those amendments to be the way they are now. Overall, in June 2024, after 2 years of intense negotiations, you member states, you have adopted in the context of the Health Assembly amendments to 27 of the 66 existing articles at that time, and you have adopted amendment to 6 of the 9 annexes, and you have also included 2 new articles. And now, therefore, we in the IHR, as amended in 2024, we have 68 articles. The key elements that you have introduced in the IHR as a result of the negotiations are captured at the bottom of these slides and regards the key amendment: the designation or establishment of the National IHR Authority, to the determination and definition of a pandemic emergency, which is now the highest possible level of alert above a fake. And then you have adopted a number of amendments related to emphasize the commitment to solidarity and equity that was so much needed after what we all experienced during the COVID-19 pandemic. And to that effect, you have introduced amendment related to relevant health product, and you have also established a coordinating financial mechanism. Next, another key amendment was the recognition of the coexistence of health document both in non-digital and digital format. And this is a very complex area that we will tackle during the next section. And lastly, you have also introduced a new article establishing the States Parties Committee for the implementation of the IHR. Now, all these amendments, next slide, please. The amendments, as it was mentioned by Dick, were not, or by Julien, they were notified to members, to states party to the IHR by the Director General in July 2024. Apologies here. They were notified in July, in September 2024 through circular letter 4024 that you should have all have seen. And these amendment, and in the circular letter, what is indicated is a very critical deadline. The deadline of 19th of July 2025, basically in 4 or 5 days, 3 days, for state parties to express any declaration, reservation, or rejection vis-à-vis the amendments that were adopted in 2024. This is a very critical deadline, because beyond the deadline of 19th of July, states parties, if they basically, by not expressing any or raising any flag, they will be indicating that those amendments are implementable and will be implemented by the state party. Then, for those of you who are still considering whether or not to communicate a declaration, a reservation, or rejection of the amendment to the Director General of WHO, please be informed that the communication should be addressed to the Director General, to DG Office at who.int, and this communication is usually transmitted through note verbal by the permanent mission to the UN in Geneva. If you have any doubt on how to go about the process, both in substance and formally, please contact us that we can sort of interact as we have been doing with state parties in other regions. The amendments, in the absence of rejection reservation, will be entering into force on the 19th of September 2025, then in a few months. And ahead of the entry into force of the amendments, we will be sharing we will be dispatching to all states parties all the communications that we have received by the 19th of July, because there is the right of objection to the two reservations. Next slide, please. Now, regarding the three parts that we are considering today, focusing on part one, which is the part on foundational articles. During my intervention, we will be focusing on the definition of national IHR authority with related amendments to Article 4, responsible authorities, and we will go quickly through the amendment to Article 2, scope and purpose, and Article 3, principles. Next slide, please. Regarding the amendment to the scope and purpose of the regulation, they substantially remain the same. Basically, protect against the spread and response with trying to avoid unnecessary interference with international traffic, meaning that sometimes it is necessary to interfere with international traffic, because during a public health event, let alone emergency, things are not expected to go better and will not be going better, but therefore sometimes very strict measures are needed related to international traffic. And in this Article 2, what was added was the verb prepare for, because this was introduced in keeping with also with the negotiations of the pandemic agreement, where there was where the importance of preparedness action were emphasized. Then, with respect to Article 3, principle, what was added was the obligation for this global collective obligation to promote and to implement the regulation, bearing in mind equity and solidarity. And we will see in the next session how these were addressed. Now, moving to Article 4. Next slide, please. In these slides, you can see in a sort of snapshot what in bold and underlined all the amendments, the changes that were made to Article 4, responsible authorities. And there were two new paragraphs that were introduced in Article 4, 1 bis and 2 bis. And we will go through the changes, amendments that were made. Now, what I would like to stress is the amendments to this Article 4, and in particular, the introduction of the National IHR Authority, is the single most important amendment that required action by the state parties, because all the remaining amendments they are mostly of WHO Secretariat concern. But this amendment to Article 4 is really of a sole responsibility of state parties. Next slide, please. Next. Okay. Now, overall, Article 4 sets out the functions of the authorities of states parties responsible for the implementation of the IHR. And it also sets out the responsibility of the WHO IHR contact point, which is the function of the WHO Secretariat for which should ensure event-related communication on a 24/7 basis with the states parties, in particular with the national focal point. Then national IHR focal points and WHO IHR contact points, which are housed by each of the 6 WHO regional offices, are the 2 entities that are dealing with events, public health events related communication on a 24/7 basis if needed. Then, specifically for the authorities responsible for the implementation of the IHR, the amended Article 4 now recognizes the existence of 3 sets. First, the National IHR Authority, which is an entity, always not a person, which is tasked with the coordination of the implementation of the IHR. Therefore, is an entity, the National IHR Authority, that has to exercise rights and obligations which have political connotations. Then we have the National IHR Focal Point, again, another entity, not an individual, that is tasked with communications related to public health events. And 3, Article 4 set forth the authorities responsible for the implementation of health measures. And this definition of authorities responsible for health measures correspond to the definition of competent authorities in Article 1, and he has a number of interpretative challenges because competent authorities is also addressed in Article 22, but only in relation to points of entry, points of entry. Then we will see in the coming webinars how we try to get out of this entanglement. Next slide, please. Now, because the national IHR authorities represent a very important step and implies a number of substantial decisions by the state parties, as the Secretariat was mandated by the Resolution 7717 adopting the amendments to prepare for the implementation to support the preparation for the implementation of the amendments. And therefore, we have developed from headquarters, together with the regional offices, considerations to guide, to assist, to facilitate state parties in their decision regarding the National IHR Authority. First, this document that you should have received from, which is in an advanced draft status, and that you should have received at the beginning of May from AFRO colleagues. This document is based on exchanges that were occurred during the negotiations of the amendment in the context of the working group for the amendments to the IHR, the WJIHR. These documents includes a level of details that is very dense, but by no means it equates to prescriptiveness. It's just trying to put on the table the possible scenarios that we could anticipate from the WHO Secretariat perspective. And of course, because the National IHR Authority is going to be a new entity, a new novelty for everybody, we will revise the document as we gain more experience. And ultimately, this document is to sort of be useful for your state party to establish or designate the National IHR Authority. Whether you have to designate, meaning attribute the function of NIA to an existing entity, or if you are going to decide to establish a NIA, meaning creating an institutional entity from scratch to discharge the NIA functions. And this document is also to assist or to help state party in the revision or development of any legal and administrative instrument that is needed for the NIA to discharge its function, and could also be used if needed for developing the terms of reference of the NIA if these terms of reference are needed at a national level. Then this document condenses all this. Next slide, please. Now, why you state parties decided to introduce the institutional entity of the NIA to discharge certain functions? Because what emerged during the negotiation is that there was a need to elevate the profile of the IHR domestically. There was a need to dispel the assumption that the National IHR focal point is responsible for the implementation of provisions that are not explicitly mandated to the National IHR focal point. That national focal point means he's in charge of event-related communication. And also, the NIA was introduced because the NFP in many countries is not adequately positioned in the institutional context. And also the NIA was introduced to strengthen the state parties' ownership of the IHR in the context of the WHO governing bodies. Then now really with the NIA you have, member state parties, you have a better opportunity to direct, to guide the secretariat, really to steer us, because the organization is yours, basically. Now, to summarize, the functions of the NIA are coordinate the implementation of the IHR within the state parties, where coordinating means bringing all the different elements of the complex institutional structure into an efficient working relationship. And to the function of the NIA would be being responsible for the implementation of provisions of the IHR that are not explicitly mandated to the NFP or to the competent authorities. And in the document, in that consideration document, did this analysis where provision article by article, paragraph by paragraph, where you can see that there are a number of articles that are or specific responsibility of the NIA, or will be after 19th of September, and there are a number of articles which require the development of operational arrangement between the NIA and the NFP, the competent authorities, or other. Next slide, please. And this type of analysis indicating what the NIA should be responsible of doing, and when arrangement, operational arrangement between the NIAS and other responsible authorities are all captured in this document in this tabular format. There are basically paragraph by paragraph. Next slide. Now, as what mentioned earlier, according to the amended paragraph 1 of Article 4, each state parties shall designate the national establish or designate a national IHR authority, an entity or one or two entities that could serve as national IHR authority and national IHR focal point. Now, then the key decision here is, and is captured in this decision flowchart, is the entity currently discharging the function of national IHR focal point adequately positioned to also discharge the function of the NIA? Yes or no? If yes, okay. If no, then is there another institutional entity adequately positioned to discharge the function of the NIA? Yes or no? If no, then you would be in the situation of having to create an institutional, brand new institutional entity. And I really would like to caution that making such a step of creating a brand new institutional entity would be really, is a sort of a high risk. Then I would really invite you that if you, by going through this flowchart, you end up in the sort of option, create an institutional entity to discharge the function of NIA, please involve the WHO Secretariat, AFRO, HQ, whoever, but it would be a very, very important step then that should be carefully considered. Next, please. Next slide. Now, after the discussions in the context of the WGIHR, basically in the context of the negotiation among state parties, the possible institutional positioning of the NIA is basically what we have understood and what we have tried to anticipate and to envisage is a very, very high institutional positioning, meaning and possibilities that we have identified would be an entity responsible, the NIA in the office of the head of state, office of the prime minister, office of the Ministry of Health, Deputy Ministry of Health, or Permanent Secretary of Health, and or a department in charge of international relations in the Ministry of Health, or the department in charge of health in the Ministry of Foreign Affairs. And this is really the kind of positioning, with very, very high political connotation, really to raise the profile and for the IHR responsibility to permeate the entire institutional context. Next, please. Now, regarding what is going to happen next with the NIA and the national IHR focal points after the 19th of July that we have mentioned earlier, we as WHO Secretariat, we will be asking, approaching your state party to communicate the contact details of the NIA and of the NFP to confirm, and after you have formally informed us in reply to the circular letter, then we will we will basically grant you access to the WHO IHR contact platform that you know for updating the contact details. And we hope that will be ready to have that platform ready for accommodating the NIA contact details very soon, because we are in the process of revamping using the platform. And as you know, we are in dear financial times. Now, the last point that I would like to make is that the NIA, the entity identified to discharge the NIA function, will be granted access to the EIS. And that's all for now. Over to Cola. Thank you.
Thank you very much, Dr. Andragetti, for this very, very important session. In the chat, I can see that people are really acknowledging the importance of the presentation, and asking if they can have this presentation. I think that this can be, we will further after the webinar, maybe they will share the presentation to them. But just to let you know that people are really acknowledge the importance of what you and Dr. Kola have presented today. So, Dr. Kola, I don't know if you have something to add to what Dr. Andragetti have presented. Over to you.
Thank you, Dr. Gillian. I will only continue from where she stopped because it's a continuation. She has only discussed articles 1 to 4. So I'm going to take on articles 5 to 14 and of course 15 to 18, just to continue from where she stopped.
Okay, thank you. Please, if you can take, because I've let Dr. Andragetti really go through the presentation for half an hour. Maybe I hope that your presentation is short. The next one is short. So please take 10 minutes or no more than 15 minutes to take us, please, this one. Thank you, and over to you.
I will try. I'll just try. So thank you, Julian, and thanks to Roberta for that presentation, for setting the tone into the IHR amendments. So the first slide is just to give you a snapshot or summary of some of the amendments that have been made to articles 5 to 18. So I'll start with Article 5, which is on surveillance. And this particular article is closely linked or related to the Annex 1, which speaks to the need for countries to build capacities or state parties to build capacity. So what has been added to this particular one is that is the prevent part. What we had in the article in the IHR 2005 expect the state parties to develop, to strengthen and maintain core capacities as soon as possible, but not later than 5 years upon entry of this particular IHR into force. So now, and those core capacities, they are supposed to be able to detect, assess, notify, and report the public health events. But in this amended one, we now have what we call prevents as an addition to it. So let me move on. And this conforms across, it conforms to all the other 3 paragraphs. This particular section has 4 paragraphs. And that's what has been added. Prevent part is critical. Now, if you come to Annex 1, which is still under core capacities, the title has changed to core capacities instead of core capacity, because we are looking at different capacities. It has been restructured and rephrased to ensure conformity. Also, the addition of prevention, they are now reflected in the annex. Prepare for and preparedness for, they also they have reflected in this. If you go through the that particular annex 1. So before there was nothing like prepared or prepared for. So we now realize, the importance of ensuring that we adequately prepare for emergency. So there's also a new paragraph which has been added. That's paragraph 4, which has to do with the obligation for state parties to collaborate with each other for the implementation of Annex 1. Annex 1, of course, it has to do with the core capacities, the need for each state party to develop their core capacities. So there is need for them to collaborate. This has also been added. And under Part A, there are items around local, intermediate, and national levels. So for the purpose of this amended part, when you have different administrative levels of a health system, you can start for the community, primary, and of course intermediate and national. So when we are looking at community and primary levels, they can be tagged, they can be categorized as, they can be referred to as local. Looking at community, and of course, and the primary primary level, primary care level. Then we also have intermediate and of course national level. And there are different capacities, core capacities expected to be developed across these 3 levels. So The core capacities have been made so explicit, including through the addition of the footnote. There's a footnote that has been added to explain if a country does not have intermediate level, that they can actually strengthen the lower level, maybe the primary and local, primary level and community level, to actually have more additional capacities. There's also the addition of health services to all levels now. Before, it didn't reflect across all those 3 levels. Then the risk communication and community engagement is now applicable to all the levels. We didn't have it before in the old one, especially at the community level. There was nothing like risk communication mentioned there. Then the addition of health products to intermediate and national levels is also it's now reflected in the amended article. So we are going to be talking about some of the meanings of this or interpretation of some of this new terminologies. Health products, we have relevant health products. Then under Article 6, of course, you can look at Annex 2, which has to do with the decision instrument. There's an addition of intergovernmental organization, which is there, especially when you have used the instruments to determine to notify a particular event. So if there's a need for you to involve other organizations that can be categorized as a competence authority, inside the old article, IHR 105, what we had there was just only International Atomic Energy Agency, in case you have something that has to do with nuclear emergency. But we have now reflected intergovernmental organization with who have the competent authority to also respond to such emergency. So not only International Atomic Agency. So this has also been added. Then when you look at the annex on decision instruments on the left box, I'm going to get to that one. I don't want to, because I want to use the decision instrument to describe this particular session. And of course, we have those that do not require the use of decision instrument, although they are part of the instrument. Smallpox is there. You have human influenza of new subtype. We have poliomyelitis due to polioviruses instead of white polio. So all those amendments will be discussed in the subsequent sections. And of course, you have severe acute respiratory syndrome under those decision instruments. Coming to Article 7, no amendments were made to that. Then Article 8, there's an addition of should, and the word member states should do in terms of when they notice unusual events in their territory. In the old article, in the old regulations, we had may inform WHO, but this time around, it has been changed to should, something that is more operative. And of course, for them to consult on which kind of intervention that should be instituted, this one we have added in a timely manner. If they have to consult with WHO on the kind of appropriate intervention that should be put in place to address such events. So timely manner has also been added to this. For Article 9, we do not have any amendments made to this. For Article 10, it has been rephrased.
Dr. Kola.
Yes.
Allow me, can you speak slowly? It seems like interpreters are not following you very well.
Okay, I will speak slowly. It's because you are the one that said I should. You give me a few minutes.
I know,
I will take my time now to speak slowly.
Yes.
Okay.
Thank you.
So it's just a broad overview. Anyway, I'm going to take my time to explain them in details as I proceed with the presentation. So under Article 11, we now have what we call pandemic emergency. We used to talk about pandemic before, but there's a reason. It has its own definition and the determination criteria, which is being used. So mostly throughout this article, throughout the amended regulations, right? Anytime you see a pandemic, public health emergency of international concern, there's also an element of pandemic emergency, so that when you are determining that, you also want to determine whether that particular emergency can be determined as a pandemic emergency instead of only focusing on a public health emergency of international concern. So this is just like a snapshot of some of the changes that have been made. Next slide. Yes, operationally, if you look at what we have here, the articles have been amended. We have Article especially under national surveillance and response system, including designated point of entry. We have Article 5, Article 13, Article 19, 20, and 21, but we are going to be stopping at Article 15 or so that have been amended from for the part I'm taking. So, and for this, national IHR focal points, I've mentioned this earlier, they're supposed to be accessible 24/7 and be able to interact or communicate with the WHO IHR contact point for the region. And of course, from there to the DG or WHO, the DG also linking up with the emergency committee to for advice around the standing or standing recommendations for that particular emergency. So this has been described before, and just to highlight those articles that have been amended, especially from 5 to 18. Next slide. So when you look at Annex 1, which has to do with core capacities, I already highlighted this before, what have been changed. We have preparedness added to it, prevention added to it. And the part 1 I mentioned earlier is about local, intermediate, and national levels. The different capacities that should be built or developed across this level, they are also explicitly stated, including the addition of new subparagraph. Like I said, we have footnotes that have been added to clarify issues around intermediate level in case some countries do not have intermediate level administrative structure. So what is supposed to be done in terms of capacities at the lower level and the national, they are well stated in this. Like I said, we have risk communication added already. So if you look at this part 2 that we use to report annually, it has been revised in such a way that to capture some of these elements, and amendment make it closer to the state party annual report. So it's so close to the state party annual report. So for the Annex 1, these are the elements that have changed there. Please, colleagues, you can look at them again. Like we said, you have up until 19th of this month for you to make your reservations or rejections. Next slide. Yes, this is the decision instrument, like I mentioned earlier. Before, among those 4 conditions that must be notified immediately, the polio is part of them. Poliomyelitis due to white type polio. Now, the white type has been removed. We now have poliomyelitis due to polioviruses, because we are looking at both white type and also the vaccine-derived kind of viruses. So we'll look at that. Then that's on the left side. That is the only change that has been made to the left side, to that part, the polio. Then for the other ones, we're also looking at those diseases that you are supposed, or the events that you can use the decision instruments to assess. For example, when you have what has been added to this is like when you have cluster of severe acute respiratory diseases in which you don't know the source. So you can also, this has been added to this. If you compare this with what we had before, it has been added. And of course, if you look at the right side, the other conditions they still remain. Other conditions that have high propensity for international spread, like cholera, pneumonic plague, yellow fever, and VHFs. So you can see this. Those are the additions that we have there, because I don't want to be going through those criteria for you to determine whether something has constituted a public health emergency of international concern. So these are the few changes we can go through it, colleagues. Next slide. Yeah, for part 2, on the information and public health response, looking at Annex Articles 5 to 14, particularly Annexes 1A and 1B and 2. So there is an article on determination of public health emergency of international concern. There was nothing like pandemic emergency before. So now we are now including a pandemic emergency, which has been added. The pandemic emergency, like I said, has its own definition, which we are going to describe in the subsequent slide. Again, there's there are different phases rephrasing that have reflected pandemic emergency moving forward. So you are going to see it in different sections of the article, under Article 12. Then coming to Article 13, we have public health response, including equitable access to relevant health products. So the addition to this particular title for Article 13 is the addition of including equitable access to relevant health products, because This was a major challenge during COVID, and there is need for equitable distribution of some of these relevant products. And of course, there is a definition for relevant products, which I'm going to touch on. And there is also an addition of prevent, prepare for, as I said earlier. We also have something like a fragile and humanitarian settings. This has been added to it. And there's a new paragraph 7, which has to do with explicit mandate to WHO to coordinate international response activities during public health emergency of international concern, including has been added to it, of course. This paragraph describes exactly the role of WHO now to better coordinate international response to emergencies. There's a new paragraph 8, which has been added to Article 13, and this is the obligation for WHO to facilitate equitable access by states. Go back, please. By state parties to relevant products. You can see how important this relevant product is because of the inequity that was experienced during COVID. There's also a new paragraph on conditional, that is conditional, which has to do with obligation of state parties collaborate with and assist each other and support WHO coordinated response. So this is something that the state parties have added to this Article 13. And coming to Article 14, we do not have any amendment there for Article 14. Next slide. So for Article 12, which has to do with determination of a public health emergency of international concern, remember, we are including the pandemic emergency moving forward. So the global early warning and response function revolve around the determination of fake. You can only talk about fake when you have something that affects the global community that has gone beyond one country. And a pandemic emergency is first and foremost a fake. It's a type of fake. Although it's beyond that, there are other determination criteria that we can use for pandemic emergency. And of course, it's the highest level of global public health alert that the DG can raise. So the definition of pandemic emergency also, it encompasses both a potential and an actual pandemic. Please take note, a potential and an actual pandemic. So we are not using the word like a pandemic again. So we are using it in the context of pandemic emergency as amended in the IHR. Like for public health emergency of international concern, the determination of pandemic emergency implies the issuance of temporary recommendations. When you have fake, you want to issue temporary recommendations. So it also applies to the determination of pandemic emergency. The determination or termination of a fake or pandemic emergency now can be simultaneous or sequential. They can happen at the same time. And like I said, by the time you declare a pandemic emergency or you determine a pandemic emergency, and we are trying to avoid the use of a declare, you determine a pandemic and event to be a pandemic emergency. They can happen simultaneously. And again, pandemic emergency is first and foremost a fake. And you are going to better understand this as I proceed with this presentation. Next slide. So for under amended Article 12, which has to do with the determination of fake, including pandemic emergency, the DG of WHO shall determine whether an event constitutes a public health emergency of international concern, including, when appropriate, a pandemic emergency. So that means that you have to use those criteria to also exclude pandemic emergency. If the DG of WHO determines an event to constitute a public health emergency of international concern, the DG shall further determine, having considered the matters contained in paragraph 4, okay, whether the public health emergency of international concern also constitutes, a pandemic emergency. So they go hand in hand. If the DG considers the public health a fake, including a pandemic emergency, as if it considers that it has ended, because it's no longer meets the relevant definition under Article 1. So both the fake and pandemic emergency, they are both defined under Article 1, just to refer you to that. Next slide. Yes, what is the definition of pandemic emergency? Pandemic emergency, of course, is first and foremost is fake. And for me to define fake, fake is an extraordinary event that is determined by the ability of that event to actually constitute public health risk to other member states, okay, including risk of international spread, and also to potentially require coordinated international response. That's the definition of fake. So if you look at fake, we have basically three components. The first one is that it has to be an extraordinary event. It has to constitute a public risk to member states, including risk to international spread. And the third one is that it potentially require international coordinated response. Those three components. That means that when you are defining public health emergency when you are defining, that's fake. Next slide. That's fake. Next slide. So for the pandemic emergencies, it has the component of fake, which is, it means fake that is caused by communicable disease. For fake, we are talking about events. It can be anything. It could be communicable disease. It could be any kind of events. But for pandemic, we are looking mainly at communicable diseases. It's a fake that is caused by communicable disease, and it has or is at high risk of having wide geographical spread to and within multiple states. That's the third one, in addition to those elements of fake. Then it's exceeding or is at high risk of exceeding the capacity of health systems to respond to those emergencies in those countries, in those states. Or is causing or is at high risk of causing substantial social and or economic disruption, including disruption to international traffic and trade. And the sixth one is requires rapid, equitable, and enhanced coordinated international action with whole of government and whole of society approach. So if you look at the criteria for defining pandemic emergency, you will see that there are 8 in number, because we have 4, starting from when it has this risk of wide geographical spread, then you are now going to add all those components of the fake to make it 8 criteria for you to define for you to determine a pandemic emergency. You can see that public health emergency of national concern, all the criteria that are there, which are 3, which I mentioned earlier. So we have 8 criteria, 8 possible combination of criteria for you to define a pandemic emergency. This is something that is new that you are encouraged to. I enjoy you to also go through this. Next slide. So this is just to give you the daily retrospective process within WHO, WHO surveillance and different assessment using different articles. Article 5 is there, paragraph 4. Article 12.12, paragraph 2 is there. So, and this involves the highest level of WHO Executive Director and Director General. They are involved in this process. And following the risk assessment using WHO tool, there is supposed to be a preliminary determination of fake. You can see that we are not using the word declaration again. We are using determination of fake by the DG of WHO. He has the prerogative to do so. So under Article 12.4, the elements to be considered by DG to determine whether event constitutes a fake. We have Part A and Part B, and of course the C, ABC, in which the emergency committee will also advise the WHO based on the information available to determine whether whether an event constitutes a fake or not. Then Article 12 empowers the WHO to determine whether an event constitutes a fake or not after receiving advice from the emergency committee. And when you now determine based on the criteria for the declaration of a fake or determination of fake, so to say, you can determine whether that particular event constitutes. So when you determine whether something constitutes a fake, like I said earlier, you also want to go ahead a step further to determine whether such fake also based on the criteria of determination of pandemic emergency, whether that fake also constitutes pandemic emergency based on those criteria or not. So if it constitutes pandemic emergency, of course, the DG can also, of course, determine that yes, and announce that. And for termination of this whether fake or pandemic emergency, the DG can terminate fake based on definition of that fake is no longer the criteria is no longer met. The criteria they are no longer met. Or the DG may also, based on Article 12, paragraph 5, the DG may also terminate pandemic emergency because definition of pandemic emergency, those criteria they are no longer met. So it applies. They both apply to both the fake and pandemic emergency. Just to give you the different processes that anytime we are talking about fake now, you also have to include pandemic emergency and try to exclude based on the determination criteria. Next slide.
Dr. Kola, 5 minutes to wrap, please. Thank you.
So thank you so much. So these are just the definitions that I can refer you to. Relevant products are usually used within the context of fake or pandemic emergency. You don't use relevant products for just normal epidemics. I won't call it normal or epidemic within the jurisdiction of the country. But relevant product means those health products needed to respond to public health emergency of international concern, including pandemic. And this may include medicines, vaccines, diagnostics, and so on and so forth. So, like I said, it is used in the context of fake, including pandemic and emergency. So they are referred to under different part of the article, under 13, 14, and up to 44, including 17 and 18. Next slide. So for the Article 13, which is on public health response, including equitable access to relevant products, there are different paragraphs, there are different items that have been added to this, including relevant products, which I just defined. The need to assess public health needs, periodic assessment of public health needs and availability, accessibility, and affordability, even during a fake or during pandemic emergency. So there is need for routine assessment of this public. These are the new additions. Then the role of WHO in coordination with allocation and distribution of mechanisms and networks. This is also a new addition. They need to scale up and geographical diversification of the productions, different relevant health products. Then sharing of product dossier for regulatory evaluation and authorization by the state party. This is something that has been added. They need to share that particular dossier. Promoting research and development. This is one area that resonates with all of what I believe, and the need for us to actually promote research and development and strengthen local production of local production. So a new paragraph has been added. That's paragraph 9. State parties to support WHO in facilitating equitable access. Even though WHO is supposed to help the state support the member states, state parties to facilitate this to ensure that there is a equitable access to relevant products. However, state parties are also enjoined to also support WHO in doing so. Next slide. So for the part 3, which has to do with recommendations, like I said, we have temporary recommendations, which we have added to paragraph 1 to 3 under this particular article. Relevant products are also being added, and those the different additions they have been reflected in such a way that they conform across all those different paragraphs. Then the temporary recommendations to address relevant health products. This is newly added. This is a new paragraph that has been added. For Article 16 on standing recommendations, there's a difference between standing and temporary recommendations anyway, which I'm going to define towards the end. There's a new paragraph added to Article 16, which is addition of relevant products, just for conformity. And also there's a new paragraph 2, which is standing recommendations to address relevant health products. So there are just a lot of phrases that have been added to reflect what we have learned from the last pandemic. The Article 17 criteria for recommendation. Now we have a new paragraph speaking to availability of and accessibility to relevant health products. So this has been well defined under Article 17 as part of the criteria for making recommendations. And Article 18 has to do with recommendation with respect to persons, baggage, cargo, container, and conveyances, goods, and of course postal parcels. So there's a new paragraph under this particular article, which is recommendations issued by WHO to contemplate facilitation of international travel and maintain international supply chains. So these two items, they have been well described under paragraph 3 of the amended of Article 18 as amended. Next slide. So these are just operational definitions of what we call study recommendations, which will be made by which are usually made by emergency committee. So there are non-binding advice issued by WHO that's standing now for specific ongoing public health risks pursuant to Article 16 regarding appropriate health measures for routine or periodic application needed to prevent or reduce international spread of disease. So it's like a recommendation to support response, but their non-binding advice is for the countries to actually adopt or adapt. For temporary recommendations, there are also non-binding advice issued by WHO in portion to Article 15 for application on a time-limited, a kind of time-gated risk-specific basis, limited time in response to fake, so as to prevent or reduce the international spread of disease and minimize interference with international traffic. So these are these operational definitions for both standing recommendation and as well as temporary recommendations. At least they are non-binding advice to member states when you have events, public health risk ongoing, or when you have a time-gated or time-limited specific risk. Next slide. So for the temporary recommendations, of course, it may include for the only addition here is that we have added including pandemic here under Article 15, including pandemic. It comes after fake. Anytime you have fake, you have to always add include a pandemic emergency there to exclude whether that particular fake also constitutes a pandemic emergency. Of course, we have additional relevant products in this, and there's another additional paragraph there, which is the DG, when communicating to member states, the issuance, modification, and or extension of temporary recommendation should provide available information on any WHO connected mechanisms concerning access to and allocation of relevant health products, as well as on any allocation and distribution mechanism and networks. So these are new additions that we have under Article 15, in addition to what I've highlighted earlier. Next slide. So under here, we have also added under Article 16 temporary recommendations. We have added relevant products is also there, and the DG2, what I mentioned earlier, is also added. The role of DG in communicating to member states on the issuance, modification, and extension of standing recommendations, which is also similar to what I mentioned under standing recommendations. Next slide. Article 17, these are the criteria for making these recommendations. You can see them. When DG is issuing, modifying, or terminating temporary or standing recommendations, the following shall be considered by the DG. The views of the state parties directly concerned, maybe where that are reporting that particular emergency within their jurisdiction. The advice of the emergency committee, like I stated earlier, or the review committee, as the case may be. The scientific principle is also applicable here. The health measures that, on the basis of risk assessment appropriate to the circumstances, are no more restrictive of international traffic and trade, are no more intrusive to persons than reasonably available alternatives that will achieve the appropriate level of protections. So additional item that has been added to this is the availability of and accessibility to relevant health products. These are the different criteria that should be considered while making those recommendations. Next slide. Almost done, Julian. So the amended Article 18 recommendation with respect to persons, baggage, cargo, containers, conveyances, and goods and quota parcels. So what we have that is new here is the paragraph 3, which has to do with the recommendations issued by WHO to state parties. Shall, as appropriate, take into account the need to facilitate international travel, particularly of health and care workers and persons in life-threatening or humanitarian situations. This provision is without prejudice to Article 23 of the regulations, and to maintain international supply chain, including for relevant product and food supplies. So these are the new additions that we have under this Article 18 recommendations. Next slide. So thank you so much. I know that we had to rush through some of them because of the limited time, and I hope you are able to really grab some of those provisions as amended. Thank you, colleagues, and over to you, Madam Moderator.
Thank you very much, Dr. Kola Jinadu, and thank you for taking us through the amendments of the International Health Regulation amended, and also to the recommendations. I know that the session has been intense, but it's really it's a very, very important presentation that you have made since we started more than 1 hour ago. I know that we have taken some additional times, and we apologize for that, but the presentation were really important, and we wanted our presenter to really go through it and bring you all the essence of this presentation. So I would like to welcome people who have joined. Now we are almost 270 people online, which is really incredible. Thank you very much for remaining there. And I would really like to ask you your indulgence to buy 10 additional minutes to go through the Q&A. I hope you have been asking your question online, and the experts have also been answering to these questions. And I will invite our EMP Emergency Preparedness Team Lead based in Nairobi, based here in Nairobi, Kenya, Dr. Miriam Nanyunja. Dr. Miriam Nanyunja is our senior emergency preparedness and risk manager. Dr. Miriam, please, I will invite you to really take us through a session on the expectations from countries and the next steps. Over to you, Dr. Miriam. Thank you. Yes, Dr. Miriam, you can take the floor in 5 minutes. Yes, we can hear you. Please go ahead. Thank you.
Okay, thank you. Colleagues, you have heard about the IHR and you have heard about the IHR amendments. I know that it is a lot, but we'll share the presentations for you to follow, and we are always available from HQ and from AFRO to give additional information as you need. Now, what are the expectations from the different countries? One is that countries, state parties must notify the Director General of WHO of rejections or any reservations to the amendments before a certain date. The DG notified countries about this in September 19th of 2024, and countries were given 9 months. Oh no, it was 9 months or whatever.
10 months.
10 months. 10 months to communicate any rejections or reservations. And if you do the 10 months, it's up to 19th of July. So as you can see, we have only 2 days remaining for countries to communicate any rejections or any reservations to any of the amendments. Any rejections or reservations after will be received up to this September, but it might not have any effect. So if any country has not had an in-depth review, it would be good to do this in the next few days and see if there are any rejections or reservations. Even you could communicate if there is nothing. The other one is state parties to make a declaration in case they are unable to adjust their domestic legislation and administrative arrangements fully to accommodate these amendments. And again, this would be before or by the 19th of July 2025. State parties should establish or appoint a national IHR authority. As you've heard, the importance of the national IHR authority, it is key now in the implementation of IHR. It should be at a much higher level, and the national focal point could be under this. And you should communicate to WHO about the agency or institution that has been appointed and the contacts. As you have all heard, the entry into force is expected to be on the 19th of September. But for this to work out very well, one of the other things that countries are requested to do is more investment in core capacities building. There's a question in the chat about what is the role of Parliament. One of the other roles of Parliament will be to advocate for more investment, financial investment, for the National IHR Authority to be able to support the core capacity strengthening. Next, or if it is not there, what I wanted to tell you again is that we need to come, countries, all participants are encouraged to come to session 2 and session 3. As you note, we have covered articles 1 to 18, and we are going to share the presentations. You can read through what we have prepared so that you are ready for the next session. If you have any questions, I hope Kola and Roberta can take some of those, but next session will be Articles 19 to 54. And we'll also talk about the third one will talk about the next steps, rather the pandemic agreement and the next steps leading to its prospective entry into force. The session 2 will have a more detailed presentation on domestication. I know some people are asking about the process of domestication. Please come for session 2 so that you get the whole context, you don't get halfway. I hope that this is clear for all of us. Thank you very much.
Thank you very much, Dr. Miriam Nanyunja. Please don't go because we are almost at the end of this webinar. And we are, a lot of people are here online, 266 people, 266 people. Thank you very much for remaining during all this event. And I will give you back the floor, Dr. Miriam, to really give us your closing remarks. Thank you very much, Dr. Miriam. You can take the floor.
Julian, you are not taking any questions at all?
Yes, yeah, okay, thank you. I can ask people maybe to raise their hand if they have any question. But I would also like to acknowledge that people have asked a lot of questions in the chat, in the Q&A, sorry. And our expert, you have been responding to those questions here in the Q&A. But let's take maybe 2 questions. If there are people that would like to take the floor, please raise your hand and I will give you the floor. Thank you.
Okay, no hands up?
No, I don't see any hands up, Dr. Miriam.
Maybe all questions have been answered. There was one question that maybe is not very clear. Roberta, someone is asking the difference between a fake and a pandemic emergency. Maybe you can quickly explain this so that they go away when it's clear. Then we'll close.
Thank you, Miriam, and thank you to the person who asked the question. I'll be trying to summarize 2 years of discussions. The reason for ending up with having a definition of pandemic emergency is to have a higher level of global alert above a fake, and to be in a position for WHO, for the Director General, to be more forceful in alerting the world when we are facing a situation like COVID-19. Because you may remember that there was allegedly some inaction when the DG determined the fake, and only when the magic word pandemic was used about a month later, on the 11th of March, then there was this sort of rush to taking action of all sort of kind. This is the first reason, having that possibility. Second, the reason for having both defined a fake and a pandemic emergency was to providing triggers for the activation and the application of provisions of the prospective pandemic agreement. At that time, we didn't know how the pandemic agreement would have looked like, but because the negotiation for the amendment and the pandemic agreement were going on in parallel, then it was clear that the two instruments had to be linked, and the way to link was providing these triggers for actions that were encompassed by the pandemic agreement. And here, action by the pandemic agreement, we are talking about production of health product in certain condition, and this was the framework. One, alert, two, triggers for the pandemic agreement. This is how we ended up that way, and there was a lot of discussion about using the word pandemic in a generic manner, and because of all the challenges that we experienced during the COVID-19 pandemic in actually defining a pandemic, there was this sort of collective decision to stick to this expression, pandemic emergency, and with the understanding, according to the definition, that is an all-encompassing definition, a sort of, yes, we are in a COVID-like situation in January 2020, or we are in a full-blown situation. I mean, the forest around the house is on fire, or the house itself is on fire. It was the whole thinking, nights of discussion. Some of you might have been there. Over. Thank you, Miriam. Thank you.
Okay,
Thank you. Yeah, Dr. Miriam, I would like there is a question maybe I would like either you or Dr. Andragetti to answer. It's regarding, someone is asking if countries can withdraw from the international health regulation. What are the consequences if a country decides to withdraw? Over to you.
Yeah. Okay, I'm going to have a go at this. I guess that implicitly some people are referring to the withdrawal, communicated withdrawal from the organization, from WHO of the US, as well as Argentina in the same situation. Internally, we are internally within the WHO Secretariat with the legal office at HQ level. What we are trying to figure out, and there are different schools of thinking at present, whether the withdrawal from the organization, which is already a legally very intricate step, would also immediately determine the ceasing being a state parties to the IHR, because the IHR entered into force in the past automatically because the withdrawing member state was a member state. Now, the moment it ceased to be a member state, then everything that he had acquired during the membership would cease to exist. This is one school of thinking. Then there is another school of thinking saying, no, because the IHR are so important, then a country that is a state party to the IHR is stuck into the agreement. But we have also to factor in better the application of the provisions of the Vienna Convention about international agreements. Then basically is a minefield in terms of international law. This is where we are. What is true? A country that, let's say that the US or Argentina, by withdrawing from WHO, they also automatically withdraw from the IHR. They cease to be a state part of the IHR if their with their state of non-WHO member states, according to Article 64.1, they can immediately communicate that they want to become party of the IHR with their state of non-WHO member state. Then if a country is is out of WHO, if they want, in 3 seconds, they can get back into the IHR proactively, if proactively communicated. I'm sorry, I cannot be clearer, but that's where we are.
Thank you, Roberta. This was really questions that is not easy to answer, but thank you for really providing these options of to answer to this question. I would like to invite the expert, please. Some questions, I think 1 or 2 questions are in the chat, in the Q&A channel. Please answer to those questions so that our participants are really fully satisfied. Dr. Miriam, I will give you the floor. I don't know, for the closing remarks. Please take the floor to take us through this step-by-step up to the end of our very important event that we are held today. And I would like to thank all the experts, all the participants that are really taken this time to attend this session. We are almost 255 people remaining online, which is really very important and incredible. Thank you very much also to the interpreters and the translators that have been helping us through this process. Thank you, Dr. Chamla. Thank you, all the experts. Thank you very much again, and see you during the next session. Please don't miss it. As Dr. Miriam said, please come to the second session. The second session, you will understand a lot again regarding this important international health regulation amended. Dr. Miriam, over to you. Thank you.
Okay, thank you, colleagues. Maybe if I may interest you in this post-session survey, you can use your camera of your phone to try and get the questionnaire and be able to scan and get the questionnaire and answer to give us feedback about this session. Would highly appreciate that. I would like to, first of all, thank all the experts that have created this time to be able to give the presentations. They took a lot of time to prepare the presentations. There was a lot that we had to summarize into just a few of these presentations. And so they took quite some time, and they are preparing for you for the next sessions. Please don't go away. Continue to come for session 2 and session 3. As we indicated, we would like the countries to take action on the requirement before the 19th of July, because by the 19th of July, then the reservations may not have effect. But also I want to indicate that IHR 2005, the member states that committed to it are committed by IHR 2005. So rejections or reservations will be to the amendments. So in which case the country will be committed to the IHR 2005 with other amendments except that particular one that you either reject or have reservations too. So please make use of the next 2 days for you to communicate. I would also like for you to have the discussions so that you can agree on the National IHR Authority. It could be the National Public Health Institute, it could be a section developed in the Prime Minister's office, it could be, but a national discussion needs to be held for you people to come up with a politically strong National IHR Authority, but also that we'll have some budget line for it to be able to implement its actions. The key issue also increasing the funding for you to implement a lot of these activities. I can see Dr. Dick Chamler back online. Dr. Dick, I'll turn it to you to give the final remarks. Thank you.
No, I don't have any more to add here. It's really to appreciate a group of our experts for your presentation and explanation, because our member states have been asking us to brief them on IHR and pandemic agreement and actually what it means. And I think we have a great start today. And as Miriam has already concluded here, there are critical issues ahead of us. Then I'm wishing you all the best. Merci beaucoup.
Merci beaucoup.
Merci
Thank you very
beaucoup.
much.
We'll
Thank
see
you.
you in the next session.
Muito obrigada.
Thank you all for coming.
Thank you. Obrigada.
Bye. Thank you.
You can send emails to any of these experts for any questions. Please don't send too many, but
Muchas gracias.